Greater Glasgow and Clyde under the UK General Data Protection Regulations and Data Protection Act 2018. This meeting will be broadcast and recorded to fulfil our public task obligation to enable members of the public to observe the democratic process. Data collected during this meeting will be retained in accordance with the Council published policies available through the Council's website. Members of the IJB are reminded that they should follow the IJB's established meeting protocols, including around the use of the chat facility, and that comments made in the chat facility are visible to all participants in the meeting, which may include members of the public who have also received invites to the meeting. So without further ado, if we can start with a roll call and then do apologies, substitutions, declarations of interest, if that's okay.
We have an apology from Dr. MacDonald. We'll now do a roll call before asking for the declarations of interest. The following members have indicated to present the meeting either in person or remotely. David Gould.
In the room.
Councillor Brennan.
Present in person.
Councillor Jackson.
Present remotely.
Councillor Quinn. Present chamber. Councillor Reynolds.
Present remotely.
Dr. Metcalf.
Present in the room.
Karen Turner.
Attending remotely.
Dr. Ryan.
Present in the chamber.
Kate Ross.
Present in the chamber.
Jonathan Hines.
Present in the chamber.
Craig Gibbon.
Present in the chamber.
Laura Moore.
Present in the chamber.
Dr. Jones. Gemma Earley. Diana Crone.
Present in the chamber.
Charlene Elliott.
Present remotely.
Donald McQuaid.
Present in the chamber.
Heather Davis.
Present in the chamber.
Stephen McLaughlin.
Present in the chamber.
Are there any declarations of interest?
Okay, colleagues, thank you for that. If we then move on to items for actions, please, the minutes of the meeting of the last meeting on the 27th of January. Do I have any questions or comments or amendments which you want to make for these at present, or we can bend to it? Paul.
Can I just ask about section 5, the financial monitoring report? It said that the report of the impact of management transfer function HSP a report be brought to the March meeting, clarifying this. I wonder if it's very relevant. Section 5, halfway down the page.
Thanks. Is that in relation to the exempt item?
No, I don't think so. It was financial monitoring, but I think we talked about the mandatory statutory functions of the HSP where going forward in budgets and said the report would come.
Through yourself, we need to take that away and have a look at that first.
I know he's up to it, but I mean, it's just going forward, that's all.
Okay.
Thanks for raising that, Paul. Colleagues, any other questions or comments? Looking around the room and I'm looking online, I'm not seeing any. In that case, are we content to accept these as an accurate record? Maybe as contempt still, as an accurate record of the last meeting? I'm seeing nodding. Okay, thank you for that. In which case, if we can then move on to agenda item number 3, please, in respect of audit committee membership. Vicky, are you speaking this, or is it yourself, Kate? Thanks, Vicky.
Thank you, Chair. For the purpose of this report, staff of the IJB to agree the appointment of Stephen McLaughlin as a non-voting member of the Audit Committee to replace Sharon Elliott.
Colleagues, any questions or comments at this point? In that case, are we content with the 2 recommendations in terms of resignation of Charlene and appointment of Stevie? Okay, and then we just say, Charlene, thank you very much for your time on the audit committee as well. It's very much appreciated. So we just note that formally in the minutes as well. Okay, in that case, if we can then move on to page 15, agenda item number 4, financial monitoring report for period 9. Faith, that's yourself.
Thank you very much to yourself, convener. This is the period 9 monitoring report. It's a standard finance paper that we bring forward every cycle and covers a number of main areas. These are mainly our current 24-25 projected position, current capital position, a reserves and a reserves position. The paper also gives an update on the progress against the savings targets to date. As at period 9, we're currently projecting an overspend of £15,000 for the overall IGIP budget. The social care budget is projecting to overspend by £111,000 and the health budget is projected to underspend by £96,000. Obviously, by year end, we will use reserves if required to bring this back into line if required. Looking and turning our attention to some of the actual budgets and a wee bit of detail of the report. Looking at our main pressures, the children and families area is projecting a £4.275 million overspend. This is mainly due to residential placements and child respite overspends at period 9. At present, we're using the non-recurring pension monies to help smooth this overspend over the next few years while the review takes place. This is an area of risk going forward, but we're pleased that additional £700,000 allocation from Inverclyde Council as part of the recent budget process to help us with the redesign work to take this forward and hopefully address this area. This is partially offset by underspends in older persons' budgets, assessment and care management, and physical and sensory. Secondly, looking at the health budget, the main area we have is the prescribing, which is overspent by just over £1 million, and this is mainly offset by vacancies across all of our main areas and predominantly in underspends and also in mental health communities. Savings review groups continue to look at this area and especially around the prescribing side of the world. The next section highlights the HSCP's progress to date and the achievements of its Inverclyde savings. And as you can see in the report, we're pleased that we've already made good progress in the delivery of these savings targets. And we have delivered most of the savings for this financial year and we're well on track for the next year. Obviously, that'll feed into the paper which is coming on next as well. Section 7 shows the overall earmarked reserves, and this shows we started the year with just over £19 million and we expect to finish the year at £13.56 million based on our current projections. Moving on to the capital section, 15.9 shows the current capital position. At this point, we're not showing significant spend to date, and it's likely to be incurred next year, especially with some of our bigger projects like the Community Hub Capital Project, which has started, but the vast majority of that work will take place into next financial year. Obviously, at the time when this was done, this was period 9 reporting, which took us up to the end of the 31st of December. Appreciate time's now moved on, but I'm pleased to say that we expect that this position we've got at the moment to probably improve further by the year end and probably bring us into a small underspend based on the current projections that we've got. But as always, happy to take any questions if anyone might have.
Colleagues, Paul.
Thank you very much. There's obviously a lot of hard work done here. If you pick up your last point, which is projected underspend, is that health, social work, or can you start about it?
Through yourself, convener, at this moment in time, it's predominantly on the health side of it, but we're expecting that to be just all the same things that have been talking about for a while, vacancies, etc. So it's mainly on the health side, but obviously just because this report was dated and takes us to the end of 31st of December, I felt it was worthwhile just to give you a bit of an update on that.
No, I think that's great. That helps. The next paper, obviously. Prescribing, is it improving at all?
There's a through yourself, there's a slight improvement in there, but it's in the margins. That continues to be a pressure for us and will continue to be a pressure into the next financial year as well.
Thank you very much.
Thank you, Paul. Any other questions or comments? Or Craig at this point? I'm not seeing any online. Craig, if you'll indulge me, one for myself, if that's okay. Just in terms of the non-recurring funding we get of 3.1 million in terms of the service redesign for children and families. I know in the next paper we speak about the 0.7 million initial allocation. What is the anticipated flow of the funds that are coming in for that? Do we know after the 0.7 million?
Okay, so through yourself, convener, at the moment, for next year, our plan is to use the non-recurring pension money again to help us with that.
Mhm.
We have got a commitment from like council of the 700,000 that's referring to us, so that's we're going to get that for continuously for the next number of years. The council are also in discussions around the council around potential additional funding in that as well. Obviously, that needs to go through council processes as well, but we're hoping to get additional funding for the next 2 years in addition to the 700,000 also, which will help with the overall redesign.
And in terms of timescales, do we have a sense of when that may be, or we may get used to that? I'm just conscious that it's quite a big ask on the council in terms of additional funding to support, and I'm also very conscious that we are doing the service redesign as well, so they are obviously interlinked. So it's just a sense of when the board will get visibility of that.
Sure. Well, what they've done as part of the budget setting for Inverclyde Council, they've committed to the 700,000.
Okay.
So that's effectively in stone, if you want to say. It's the additional money that we're looking at is probably going to be discussed in more detail during the next financial year, and will definitely be in place when we set the budget for next year. We will make that commitment at that point.
Okay, thanks for that, Craig. Karen, I see your hands up.
Thanks very much. Thanks, Chair. It's an observation, I guess, linking the papers, the rest of the papers, some of the other papers in the pack. And it comes back to the point that you've just made on the children's services and the redesign of those. There's some very key data in the paper from the social work team on the number of children who are looked after and the cost of placements. There's some very important words on the perinatal and infant mental health services and how critical they are, again, to supporting children and young people being looked after by their own families within Inverclyde, and the work that we all need to do together to help families be successful under some very difficult and challenging times. And so I think all of this comes together to re-emphasise the importance of the service design work, making sure that we are able to use all the money that we get in, and really have all of these different ambitions and targets, bring them together and make sure that we're not inadvertently jeopardising one by some action that we might do in another one. So it isn't a question, David, it's more a concern and a recognition how hard everyone's working to try and do this, but we all need to be mindful of decisions made in one place can be really adversely impact on another.
Thanks, Karen. I think that's a really good comment you've just made, and very much support that as well. So thank you for that. Okay, I'm looking around the room and online. Jonathan, are you want to come in at this point?
For yourself, convener, it might just be helpful to refer back to the paper that Karen mentioned in terms of the children and families redesign, and that clearly does consider the whole system need for improving outcomes, building on the really good practice that we have, not just for children who are looked after away from home, but children who continue to live with their families, and really looking at family capacity building as part of that, as well as looking at children who require to be looked after away from home as well. So just to offer that assurance again that it's a whole system redesign to look at the range of risks and needs and vulnerabilities of children and families looking at. Thank you.
Thanks, Jonathan. Very much appreciate that. Colleagues, any other questions or comments at this point? I'm not seeing any. Okay, in that case, great. Are we content to take the paper as is? Seeing nodding heads. Excellent. Okay, thank you for that. Now moving on to the next piece of business, the Inverclyde IJB budget for 2025-26. And again, Craig, this is you.
Thank you very much. Through yourself, convener, I wasn't going to spend a lot of time going through the report line by line, and this is mainly because we've had a number of development questions over the last while in relation to this. I do want to just highlight a few areas as part of the overall report. But first of all, I want to a huge thank you to my fellow colleagues and SNP members for the amount of work that's went into do this and the amount of work to do around savings. Also want to do a special thank you for teams and some of the individuals in my own team, the finance team. Special thank you for Helen McGuffin and Jason and her work. They've helped me intensely in the background through this process. So moving on to the actual report, I just wanted to highlight some of the recommendations for the report that we've got. Today, we're asking the IJB to note both the funding contributions from both the partners, and that being Inverclyde Council and NHS Greater Glasgow Clyde. I'm asking for the IJB to formally give delegated authority to the Chief Officer to accept the formal funding offers from both partners. Asking for the IJB to agree the net revenue budgets as highlighted in the report. Asking them to note the progress of the savings and the budget adjustments in section 4 and section 5 and approve the additional £400,000 saving in relation to the new voluntary early retirement and voluntary redundancy exercise as mentioned in section 4.5, and this again, similar to this year, has been in terms with the current council arrangements they have on that particular issue. I'm asking for the IJB to approve the release of the posts identified under 4.5 under the Inverclyde Council voluntary redundancy scheme, and to tell the IJB that these releases all meet the value for money criteria as per Inverclyde Council policy in this area. I'm asking IJB to note the reserve position in section 6 and asking IJB to approve the updated financial plan contained within Appendix 7. Obviously, I understand there's a lot of work that went into this in the development sessions we had, but we had lengthy discussion at that point. As always, more than happy to take any questions any member of the IJB might have at this point.
Thank you for that, Craig. Okay, colleagues, I'll open it up. And Paul, I think you're up first, or was it yourself, Diana? Sorry.
I've got a number of questions I'd like to ask, but the main point, I think, is that we have been underspent because of job vacancies, and the staff have been working because we haven't been able to fill posts or recruit to them. And yet the main proposal for further savings is to get rid of more staff, which worries me quite a lot because obviously it's going to put more pressure on the ones that aren't there. I know there are particular areas of concern and they're not the ones that's going to be offered voluntary redundancy. In terms of business support, I understood that the savings we're making from that was largely due to job vacancies that would be coming up imminently, and that was a year ago. But you're still marked down as not having made any savings on as of the end of December. So I'm a bit concerned there's more savings, and with the VR exercise, there are more people to go. So I do have a concern that we're in a better financial position than a lot of IJBs, but part of that I think is because we haven't got the staff and I don't want to put them under more pressure. Could I ask a question? In 1.4, we're getting money from the government for children and young persons mental health funding. Is that different from the money that's being taken away? I take it further on.
Yeah,
Thanks, Diana. Craig.
For yourself, Convener, I'm happy to come in here. First of all, the last point you made there, know that that's just our allocation we've got for this year, so we know that's there's no money being taken away from us on that side of things, and that's in line with what we'd have expected for this financial year, sorry, for next financial year. The other point I just wanted to clarity was the business support saving. We have made that in full. We've made the full 300,000 by holding vacancies, and we've actually reached the requirement of the health board, which was to bring that down to 2018 levels. We're at that at the moment, so just wanted to say that for clarity.
Kate?
Yeah, so that is in line with the health board's expectations around business support, but the redesign of business support continues to look at the processes and the modernisation of business support moving forward. We felt it was better that we held vacancies than went for VAR because A, has a better impact for the workforce and allows the workforce to redesign with us. So that is still our ambition.
Diana, do you want to follow up on that at all? You content with that?
I'm just a bit puzzled why we've got them down as further savings unless it's to do with the systems change that we're doing in business support.
Through yourself, I can check that there, but I can just say for clarity, we have made those savings. So if there's maybe an error or a typo in that, I'll have a look at that, but happy to say for clarity that we have made those savings.
Okay, thanks for that, Craig. Moving on, Becky.
Thank you, Craig. That's with a bit similar points there, and I think obviously I'm here representing the health board, so the voluntary redundancy process is new to me. So and thank you for discussing it through the development sessions as well, if that's been helpful. I can see obviously that this process is going forward and we're here to approve that. The question is just similarly, what are the risks to losing, not just losing these staff, but mentioning losing these posts then as they stand? So what are the risks, and are there any services in particular at risk for that?
So I'm happy to come back through yourself, convener. As is obviously the case when you look at staff, there's potential risk, but the SMT, as part of this voluntary redundancy additional exercise we're putting forward, we're planning to look at where we see the main areas where we can make these without having any significant impact on the service, on the frontline services that we deliver, which is what we've done for this financial year as well. So that's our that's a commitment at the moment, is that we will look at where we think that will have the least impact on that. I don't know if any of my colleagues are wanting to come in with that.
I'll come in. So each post was risk assessed, Becky. So it looked at impact, and mainly impact for the public, and whether that the tasks could be integrated into other job functions, or there was a level of duplication in other job functions. So in the main, that is what we've done. And in the main, that because we're doing the integrated front door, we found that as a result of looking at some of the efficiencies of who you would put at a front door, some of the duplications of processes, we were able to release staff as a result of it. All staff that we're releasing have voluntarily asked to go forward with it, and in the main, well, I think 100% in the main, they are happy to go. And actually what we are using is different ways of either through digital processes, development of apps to be much more efficient. So a lot of the activity, we had 4 front doors, we're taking it down to 2. So the actually by bringing that, you are bringing efficiencies with that as a result. And I think we'll have a better sense of the outcomes that we want to achieve, because it's hard to manage 4 front doors. It's easier to manage 2. So I hope that provides a level of reassurance. All of the heads of service have been involved in it. We've ensured that all registered workers, all regulated workers were protected through this process. So no nurses, no social workers, no social care workers in the main have, these posts haven't been deleted. So we're trying to continue to have that outcome as we move forward, and because this isn't going to be the first or the last time that we're going to be here, I've got no doubt, because of some of the financial pressures, but we have to do it in a sensitive way by the use of our data and looking at the impact on performance, and that's all done.
Well, thank you. That is really helpful, actually, because I think just to assure ourselves that by losing posts, that work's not automatically, shifted. It's about general efficiencies and changing how we work. It's really helpful. Thank you.
Thanks, Kate. Thanks, Becky. Paul.
Can I ask about similar to what Becky's asking about voluntary redundancy, which I'm asking nothing. It says in table 4.7 around the voluntary redundancy of 400,000. We'd also haven't used temporary reserves. Is that a timing thing, or how confident are we to move that? And also, the other thing I'd ask about is in 5.2, you talk about temporary reserves from the prescribing earmark reserve. I think that may reflect your previous comments about getting more imbalance, but am I reckoning that would exhaust your prescribing earmark reserves? So how much of a risk is it using earmark reserves for these things temporarily?
Through yourself, convener, you would always rather not use reserves, but given the position where we're in, we think that it's reasonable to do that. Taking the first point into account with the use of the reserves from earmark from the voluntary redundancy, you're correct, that's just a timing issue for us at the moment, where we have pretty much got those savings in the bag, if you want to say, but because of the timing of it being this close to the end of the financial year, we just wanted to build that in as a buffer for us to help us for next financial year. So the main priority, I suppose, I've got is getting the savings documented and agreed, which we've got. And it's just the actual timing of that, because there's obviously some HR issues around that as well, about people actually leaving their posts. And that's just buying me a bit of a buffer, to allow us to actually deliver that in terms. So we've got that there. In terms of the prescribing side of it, you have seen what we've done is for the 3% uplift we've had in the non-paid element of health, we've pretty much put the vast majority of that into prescribing to help us in that position. So, and there's obviously the savings initiatives into next year as well, nearly 800,000. So there's quite a lot there that's going to help us with that. All we're really doing here is trying to just trying to put it through reserves, and we monitor that on a month by month basis. But considering, I think what we're saying there's £218,000 in comparison to maybe some of my other colleagues which I've spoken to, other IGBs, that's actually fairly a small amount. I'm certainly comfortable with that at the moment.
Well,
Thanks, Craig. Paul, you want to come back?
No, just to commend you. This is the third budget setting meeting I've been to. This is far and away the easiest. Can I say?
It's not through yet, Paul.
No, apologies.
Colleagues, any other questions or comments for Craig and the team at this point? I'm not seeing any. Just a point for myself, Craig, if you'll indulge me. Just thinking about the next 5 years, we've also got Appendix 7, the 5-year financial plan on page 19. And we've got quite a significant budget gap we're looking at in 26-27 of £5 million. So it'd be good to know for the board what your thoughts are in terms of how we approach addressing this in terms of timescales. Obviously, this year, I have to say, I was very impressed in terms of development sessions that we had, the time that was taken with all the members as well. I know fellow members actually were able to approach you separately offline with questions and comments, which I think is a really good way of working. From my perspective, personally, I won't speak for the board, but I found development sessions excellent in terms of getting a really good detailed understanding of the challenges we face, particularly around children and families as well. So that was particularly helpful to give context. So what I'd like to know is timescales. I don't anticipate that we're going to be leaving the budget planning until towards the tail end of the year. I'm wondering when we're going to start working on this road, if you will.
So through yourself, you'll be pleased to know we've already started that work on it, and we're well on the way with that. There's a number of things which are going to factor into this. This doesn't include the additional money we've got from the Inverclyde Council. That will move forward in the next number of months through Margaret and the team, and that will help us in that overall position. We've already started as an SMT looking at some of the voluntary redundancy exercise. We met about that last week, so it's full in my intention over the next number of weeks, as soon as this is agreed, is to start working on the savings for the next budget. So we've pretty much got that in hand.
I had no doubt you would. Just in terms of timescales for us as members of the board, I'm wondering when your initial thoughts, we might get initial sight of those proposals.
So I would imagine we would be into probably the September or the October session that we've got. That's probably once we get the year-end accounts out the road. By that point, we'll have hopefully developed a lot of that work, and we'll be in a position to bring that forward. And that's generally the timing I bring forward for the overall budget exercise we're working. So we'll tie into that.
Okay. I'm looking around the room, I'm seeing nodding and agreeing, so this is good and online as well. Okay, in that case, colleagues, we have a number of recommendations at 2.0. I don't propose to go through all 10 of them. I'll just look around the room and online and see if we are content with the recommendations that are presented to us in this paper and we're content with the budget. I'm looking around, I'm seeing nodding, I'm seeing online, I'm seeing nodding as well. Okay, Craig and the team, well done. Now we've got to deliver, so no pressure. Thank you, colleagues, for that. Okay, if we can then move on to the rolling action list, item 6, which is on page 37, and I suspect this will be fairly simple to do, as everything is proposed at this? Is there anything we need to draw attention to, or are we content with this? That should be accepted as closed. Craig?
Thank you again. Just very, very briefly, again, this what we do is we bring this every cycle, and it just highlights the main work that the SNT and the IJB are looking at in the next number of cycles. I think it's the next 4 or 5 cycles we show there. So it's just, as I say, highlights our main work plan of what we're dealing with. But as always, happy to take any questions or comments on the content of it.
Colleagues, any questions or comments for Craig and the team? I'm not saying once again, Craig, you're on a wee easy ride today. Well done. Moving on then to agenda item number 7, enhanced mental health outcome framework. That'll be yourself, Kate, or Katrina. Yourself, Katrina. Very much.
Thank you very much for yourself, convener. The purpose of this report is just to provide an update to the IJB on the revised delivery plans on programmes funded through the Enhanced Mental Health Outcomes Framework. And the IJB might recall that we did bring, as part of the overall finance report in November 24, the news that we were experiencing a reduction of around 5.4% in the overall Enhanced Mental Health Outcome Framework. And at the time, we noted that there was minimal impact directly to our directly provided services. We were able to absorb that reduction with the deletion of a vacant project manager post, which allowed us to continue some of our ongoing development work around delayed discharge coordination, and also our care home liaison, nursing and psychology posts going forward. So as I said, within Inverclyde directly managed services, we managed to absorb that reduction relatively well. This report actually provides an update on the revised plans for the delivery of our board-wide programmes, or where we contribute to services that are hosted out with Inverclyde HSCP. So at section 3, you'll see actually what the Enhanced Mental Health Outcome Framework provide around some of our board-wide services, psychological therapies, our adult and children's eating disorder services, and our child and adolescent mental health services. It also provides information on our perinatal and infant mental health programme, our school nursing service, and the annual health checks for people with a learning disability, which, although the funding is allocated to individual HSCPs, it's that particular activity is planned, coordinated and delivered by East Renfrewshire. Sorry, and Action 15, which the HSCP funding, which supports the local activities that I mentioned, but also supports a number of board-wide programmes that allows us to deliver and to work towards the delivery of the mental health strategy. So in terms of impact on programmes around this reduction, the financial impact of the reduction in allocation across all the programmes is detailed in the tables at Appendix 1. Within Specialist Children's Services, which is hosted in East Dunbartonshire, the reduction in funding equates to around 9.4 full-time equivalents, and the service are targeting vacancies and fixed-term posts to deliver on this. And they anticipate that the CAMS will be able to maintain their 8-week referral to treatment standard with a continued focus and allocation list by doing this. Within the psychological therapies across adult mental health services, there is a reduction, and the reduction in allocation equates to around 6.2 full-time equivalent assistant psychologists and clinical associates in applied psychology and counselling psychologist posts that are currently vacant. And the impact of that will be spread across all HSCPs. So these were board-wide posts that were enabled us to target areas with high waiting lists. And unfortunately, because of the peripatetic nature, we've been unable to completely fill those posts as people have moved through. So the impact, we hope, will be very minimal in terms of the actual referral to treatment time target. The adult eating disorder service will receive no reduction to their allocation, and actually there is an ongoing review of our adult eating disorder service to improve the service delivery and to look at meeting some of the standards that have come out of the Scottish Government review of services. And so we'll also explore the benefits of a potential flexible day service, which again should allow us to increase capacity and support some of that activity from the wider HSCPs in relation to targeted support from the Community Eating Disorder Service. Perinatal and infant mental health. There is a reduction in funding that will be equally split between specialist children's services and adult mental health. There has been significant investment in the community perinatal mental health team over recent years, alongside the mother and baby inpatient service, with an increase in psychology and psychiatry resources. So how they're meeting that reduction has been achieved with the removal of a research assistant role and a project manager, both of which were in place to support the establishment and development of the teams, and therefore, again, the impact will be minimal because it's not direct frontline posts that are being reduced. In terms of the school nursing service, the programme for government commitment was made to increase the number of school nurses across Scotland by 200 full-time equivalents. NHS GGC's allocation equated to an uplift of 56 full-time equivalent school nurses by December 23, and the reduction in funding of has reduced this commitment to 50 full-time equivalents. Inverclyde are currently over their funded staffing number, either in post or in training, and therefore will work alongside the other HSCPs to realign staff if necessary when training is complete. We're 0.4 full-time equivalent over within Inverclyde. Annual health checks for people with learning disabilities. In 2022, the government committed to an annual funding of 2 million for NHS boards to offer annual health checks to all adults with learning disabilities. The planning for, as I said, of the delivery of the annual health checks is managed by East Renfrewshire as the host area. But all health boards across the country have highlighted to the Scottish Government that the original funding envelope was insufficient to deliver on the aim to offer annual health checks to all people, and therefore they have reviewed this to look at regular and health checks for some of our more vulnerable clients within learning disabilities. And they will look to prioritise the people who are most in need. Action 15 of the mental health strategy, as I said, in terms of our Action 15 monies, we had minimal reduction or minimal impact within our directly provided services. However, a proportion of our Action 15 money goes to specialist mental health services in treatments such as our mental health assessment units, police station custody suites in prisons, the adult mental health liaison service, psychological interventions in prisons, and the borderline personality disorder service. In terms of the financial commitment to each programme is detailed at section 5.24, and this shows our contribution to each of those individual programmes and our overall contribution. I would say that in our financial planning alongside Craig and his team, we have factored this into our planning going forward. And therefore, what we are asking the Integration Joint Board today is to note the contents of this report, note the impact of the funding on each of the programmes, and approve the proposed funding arrangements to deliver the programmes in 25-26. I'm happy to take any questions.
Katrina, thank you for that very comprehensive run through of the paper. Excellent, thank you very much for that. I will open it up. Oh.
Sorry, I don't really want this bit. Part of your problem seems to be you got a 5% cut 6 months in the financial year, which must be like incredibly difficult for you there. And those from the paper, your proposal said very sensible that you argued from there. Going forward, understand some of this will be mainstreamed. How much of this will be mainstreamed if you don't find this situation next year?
As far as I'm aware, it's all going to be baselined next year. Mm-hmm. So, and the assumption is that the funding that we were allocated in September 24 is the funding baseline that we'll get going forward, plus any addition for pay rises, etc.
Thanks, Paul. Becky?
Thank you for this paper, Katrina. And we touched on it at the audit committee, but just for others to think, so I was reading this paper alongside the risk register, which currently has a risk that we discussed earlier about medical staffing and mental health, and I suppose the impact being the reduction in services. And I suppose just with this paper, I was wondering if we needed to maybe review that in terms of the mental health service delivery, the wider staff groups, given it is a multidisciplinary delivered service, quite complicated, I think, what I'm trying to explain. And I suppose one of my concerns about that was, which you did kind of answer there, was it does say in the paper that the decrease in overall psychology may impact on our in future performance in terms of the referral to treatment standard. So, but you said that you didn't think that was going to have too much of an impact on Inverclyde, and I suppose that's really helpful, because what I was thinking was, given our current recruitment and retention challenges in this specialty, then if they are removing services, albeit board wide, but would be slightly higher risk just given the existing shortages. And then, if so, do we need to articulate that in the risk register?
Thanks. I think in terms of psychology in particular, we've actually invested in psychology services as part of our Action 15 money. So we've invested in psychology service to enhance our care home liaison service. We've also allocated funding for psychology services within our inpatient areas. But I think over and above all that, at this moment in time, there is a review going on across the health board, which I chair, which is the primary care mental health team review. And, you know, you'll be aware the primary care mental health teams are pretty much usually responsible for us meeting our referral to treatment targets. And the recommendations that come out of that review will allow us to look at not only efficiencies, but to actually look at the workforce and what we need to be able to continue to deliver that. So there'll be an element of service redesign, I think, that allows us to minimise the impact of the funding, and but will also allow us to look at, in much the same way as we're doing across the board, different ways of being able to deliver that. So again, primary care mental health team, we're looking at how we can share resources across HSCPs in terms of group therapy, in terms of digital therapy, expanding CCBT. So I think we've got plans well on the way and identified within the mental health strategy that will allow us to minimise any future impact for certainly our psychology services.
You happy with that, Becky?
Yeah, I think so. I think for me, it seems like it's a really important service, obviously, and Carol's already highlighted that it does seem quite vulnerable in a number of different ways. And I suppose it's for us to be able to get that view of all those moving parts. Thank you. Let's try to put it all together.
Thanks, Becky. I'll take Karen, who's online, and take Francesca.
Thanks very much, and a really good and helpful paper, Katrina. And I was quite comfortable until I heard some of those words which send shiver down my spine when we're looking at how we potentially change the service model. So we must stick to what we know works. So when I was director of mental health in England, and the evidence base for psychological therapies for CBT, particularly for common anxiety and depression, is very strong, so long as we follow the rules of the number of sessions, the number of people, and so on. That's how we get the outcomes. And so I would urge us not to start to dilute the offer for individuals who have the service, because it just doesn't work then. And then, you know, we need to be very clear that we're doing what the evidence tells us works, and that we're monitoring our outcomes continuously so that we can check we're getting the results that we're going to. I'm sure that you're not thinking of diluting, but we mustn't allow anybody to encourage us to reduce the number of sessions, increase the number of groups, and so on, because our experience is hard in that area. Thank you.
Thanks, Karen. Katrina, can you give us the assurance that Karen?
What I can tell you is the recommendations that are coming out of the primary care mental health team will require Inverclyde to invest psychology time into our primary care mental health team. I think the issue is that the primary care mental health teams across the board operate very, very differently and have very different models and very different staffing profiles. And there are also several more specific therapies that are only available in some parts of the board, so you end up with a bit of a postcode lottery. So things like EMDR, for instance, is only available in one part of the board, it's not available elsewhere. So the review is looking to see how we can maximise that access for everyone across the board, but also ensure that we have that professional governance for any service delivering psychological therapies, to enable us to continue to deliver a mixture. So there will always be direct face-to-face sessions, there will be digital sessions, but we think that also by increasing access to group therapy sessions, which again is not hugely accessible across the board, or there isn't a big uptake across the board, that by encouraging that we will reach more people. And some people actually prefer that to the direct face-to-face. So I think what I can safely say is we will continue to have a range of options available for people within our who would access our primary care mental health services.
Karen, you content with that?
I am content and grateful for the thoroughness of the response as always from Katrina. I think if there isn't an evidence base for something, it doesn't mean it's not going to work, but it does mean that we should be testing it and see, because it may well be that we can come up with a service model which is actually much better delivered by our experienced psychologists. But then we need to capture the data and put it through some sort of review and then say, actually, this works for our residents, and we know that because. But otherwise, we need to be sure that we adhere to treatment, because we're selling people short if we don't. But you know that, and we're grateful. So thank you.
Thanks, Karen. Francesca.
Thanks very much, Chair, and thanks so much, Katrina. That's such a comprehensive report and really comprehensive narrative around it, so really appreciate that. And I know that you're doing everything to give us reassurance about the impact of the reduction in funding, but I suppose I think we all know that a reduction is very much a reduction. So I'm just going to pick up on item 5.25 about the preparation that had been underway for the board-wide neurodevelopmental pathway, and that Inverclyde HSCP have been going to contribute to that. So I see that the reduction means that there's no longer going to be any sort of implementation of a specialist service or that pathway. But that section, as you know, details like the really sort of words like unprecedented, really high numbers on waiting lists, unprecedented referrals. So I'm just wondering if you can say a wee bit, if it's fair to ask, about what that sentence about the options to manage the referrals and the waiting lists being explored might mean, if it's not too early to say and not unfair to ask you about that, Katrina. Thank you.
So I can answer a little bit of it maybe, and then maybe come back at a later date. We are looking at different options, and part of the reason for that is the vast majority of referrals to mental health services that are related to neurodevelopmental issues don't have an accompanying mental health problem or mental health presentation. So some of the options we are looking at is doing that kind of RAG risk rating around, if you have a neurodevelopmental issue and you also have a clinical presentation in terms of mental health issues, what will that mean, and how do we make sure you get that help as soon as possible rather than being on the waiting list? So there is a paper that's gone to the NHS board around how, as a whole system, we will manage that. There were some amendments to be made to that paper before it came out publicly and before it went back to the board. And as soon as that paper is able to be released, I'd be happy to bring it here.
Thanks, Katrina. Kate, you're going to
So just to add to that, because I've got a particular interest in ensuring that this is whole system wide, because a lot of the individuals that are waiting or that there's concerns aren't always necessarily known to health either. They're sitting in the social work world, they're sitting in addiction, they're sitting in criminal justice, they're sitting in sometimes families in the generic way. So I'm keen that we look at that as a whole system and not just around, because for many adults, they will not require any medication. They just need that diagnosis to understand what that they're dealing with or what they're not dealing with in life and to move on. So I think that there's such a wider discussion around how can we do that as a whole system, and particularly in the world of addictions where you have got clinicians there. So it is a particularly for ADHD in terms of the neurodiversity, but we can see that has increased as a result of the pandemic, and for some reason many more adults are presenting with a level of demand in that area. So just to kind of advise the RGB that we'll be keen to have a wider discussion about where it sits.
I think the Chair very much welcomed that discussion. This was one of the things that stuck out when I was reading the paper. Just in terms of, if you want, conversion rate, if we've got effectively 6,500 patients on an ADHD waiting list waiting to be diagnosed, I think the average wait time is 2.4 years. What's the conversion factor between someone being referred and then a positive diagnosis? Is it quite high, or is it low, or somewhere in the middle? Just to get a sense of, is it a realistic level of demand we're looking at, or is it a high level of demand but the number of diagnoses are quite small? I don't have a sense of it, so I don't know if you can speak to that, Katrina, or not.
Probably not, if I'm absolutely honest, and I think the reason for that, A, is because of the high waiting list and us not being able to see people. B, a number of people on that waiting list will have had a diagnosis from private clinicians, and then they come onto our waiting list for treatment. And I think Kate's point is absolutely right. Not everybody on that waiting list actually requires treatment. And I guess that whole system approach is, who does do that diagnosis, and is that diagnosis actually going to be beneficial or not? It's not always beneficial to put a label on something. And where would that sit? I think by default it has automatically come through ADRS, mental health, etc. But actually it's not mental health issues. It's not, that isn't the reason. In terms of substance misuse, it might not be as a result of that. So where do they sit? Where do they get that help? And obviously we don't want to push people into having to go for private diagnosis either, but it becomes really challenging for once you get that private diagnosis, because nobody then will prescribe you the medication. So I'm not able to answer around the conversion rate because of the length of time people are waiting for that diagnosis.
Okay, Katrina, thank you very much. That was very helpful. Colleagues, I'm looking around the room. Any more, and online, any more questions or comments at this point? Okay, we've got three asks. Note the contents report, note the impact of the funding in each of the programmes, and approve the proposed funding arrangements for 25-26. I'm looking around. Can I see nodding of heads or shaking of heads? I'm seeing nodding of heads. Okay, I'll take that as approved. Thank you very much, Katrina. And colleagues, thank you for your questions. In that case, if we can then move on to, I hesitate to use the words good news story, but in terms of Inverclyde HSCP's response to Storm Aylwin on page 53.
If I could just, from the subtext, that IGB asked for an update around Storm Aylwin, and Alan Best will present it as a result of it, but this was a direct request to see how that we managed the impact. So I'll hand it over to Alan.
Thank you, Alan.
Chair, thank you, Kate. Yes, and apologies to the Welsh nation if the pronunciation is correct or incorrect. We're hopefully getting there. The report updates Inverclyde HSCP IGB on the HSCP and the collective community response to the impact of Storm Aylwin, on Friday the 24th of January, and also the continuing impact over the weekend period of the 25th and 26th of January. Just to say, this report in no way captures all the individual stories that happen collectively across the community, but hope, and apologies to those that feel they don't get a mention because it was a great community response, but it hopefully picks up in sort of the wide aspect of response by the HSEP and the wider community and voluntary services. The report also highlights the preparation, prioritisation and development of the HSEP services, working alongside our colleagues, our Civil Contingency Service, Inverclyde Council, Commission Services and our community partners. A sample of activity is listed in the report to advise IJB on the activity during the period, probably with a particular focus around critical support to our community, as well as in particular some care homes that were within a rural location. The report also highlights the ongoing learning from the service response to Storm Evan prior, during and the aftermath. Colleagues from our Civil Contingency Services are collating this learning from the service response collectively to the storm for both the HSEP, the Council and other Priority 1 responders to ensure that this learning is taken forward in future scenario training, and also how we respond to future incidents, and also to see how services respond to that. In terms of one of the interesting bits about this particular storm was the duration, especially around power outages. Most folk who live in an urban location are used to power outages to be a couple of hours long, whereas in this instance, because it was a national picture, the outages actually were prolonged in some cases up to the Sunday night before areas of Inverclyde were reconnected. So there's learning around that, and HSEP will work in partnership with our commission providers to ensure that business continuity plans are robust and take into account the scenario where extended power outages are experiences, and that the availability of portable electrical generators should be available, especially where we have care homes at more rural locations, which were particularly impacted this storm due to falling trees and blockages in the road. Commission providers should also hold a contingency stock of extra bedding and personal care supplies. Also, we know where in the rare event a national red alert travel advisor notice is issued, that staff are supported in working from home where possible and no unnecessary travel takes place. But as an HSEP, we also recognise that this is not possible for frontline staff with direct health and social care duties, and that we manage staff visits to only essential and critical care, and this is managed through our business continuity plans and resilience partnership. The senior management team will also develop and progress how we manage our out-of-hours system to coordinate future events with rotational role amongst our trained senior staff. We recognise also we have staff who stay locally and staff who stay out with Inverclyde, and depending on the type of contingency we're dealing with, folk might not actually be able to get to the geographical location, so we make sure we've got a broad spread of experience to help cope with any eventuality. Happy to take any questions.
Thank you, Alan. Paul.
Sorry again. First of all, to commend your staff, that was an extraordinary job you've done in a long period of time. Our last health board was verbal update from Public Health about their response and how they've been coordinated there. So I'm very keen this report was sent to the Public Health and the Health Board as well, because there are certain issues, because I'm not aware of any other health nursing homes in the area without power for that length of time. Issues that arose, such as laundry, it's not something I'd snap based on any scenario. So there are many workarounds there and also funding. So basically, commend the staff and ask if you share all your findings with Public Health for their report on a board-wide basis.
No, thank you.
Thanks, Paul, for that recommendation. Becky.
Yeah, thank you so much for this, and again, commend the staff for everything they did. I was just going to ask wider a question actually about business continuity plans and the process for reviewing and testing those in the HSCP.
Yep.
Also up to date.
Kate.
So as a consequence of the impact for the nursing homes, the commissioning manager is working with our nursing home providers to look at their business continuity plans, because obviously these are commission services, they're not our services. So we need to ensure that if you're in a rural location, that you have the business continuity that's in place. So that's been part of the learning for us. Whilst that we do very thorough quality assurance around, as you can see from Arlene's report, we've added on the business continuity plan.
Thanks, Becky. Thanks, Kate. Alan, just a question from myself. I'm trying to get my head around in terms of balancing risk. I'm conscious that the likes of the district nurses, they basically worked around it, go early or go late to avoid the worst of the storm. Obviously, we had a red warning, do not travel. I'm wondering how we reconcile that with the need to potentially visit patients who, if they don't get the medication, could be in a very serious condition. So how do we balance the two safety requirements? If you, how do we get to that point? It's something I mean, personally, I'm not sighted on. I don't know. It feels operational, but I think as a board, it'd be good to have an understanding of how we do that, just in terms of the risk appetite.
I'll maybe just kick off and maybe pass over to Laura as professional supervisor. But across all our services, we obviously we are aware who our sort of vulnerable service users are. So we regularly make sure that list is updated, checked, and something that's a first port of call. But each service themselves will have to do their individual risk assessment about the safety of travel. But in terms of sort of the community nursing, I'll maybe pass over to Laura in terms of that one.
Absolutely. So thank you. So in terms of our biggest risk and concern was the individuals that we look after in terms of the diabetes care who required their insulin, which is absolutely morning and night. Some of them, there's a significant number of them. But because of the timing of the storm, we were able to manage that quite effectively. Had the storm been at different timing, we might have had to give them more significant advice around diet and they get more assistance from family members, that sort of thing. But actually the storm was, because it was in the middle of the afternoon, we were fine. Our biggest concern was an individual out at Colliers, and I think we talk about it in here, but somebody actually walked across the fields to ensure that they got their medication on time. So our staff were outstanding. But yeah, we would have had to potentially put in more around that had the storm been at a different time. But we were planning for that if it had gone on longer.
So going forward, I guess we can take reassurance that we are planning for that, and when we're looking at business continuity plans, we're well aware of it. That's what we're telling me, which gives me assurance.
I think it's fair to say our community, our community teams are well versed on all of this and are a little bit, what are you all fussing about, because this is what we do. I mean, that's the sort of response you get from them, but they're absolutely on it with it all, and we're prepping well in advance of the storm actually.
Great to hear. Thank you very much for that, Howard. Colleagues, are we content with this? Okay, I think if we could just formally record as a board our thanks to everyone involved in this. This was above and beyond. I think in terms of what was achieved, it's very, very impressive as seen from this paper. As Paul says, if we can share this as well, I strongly encourage that. You can do that. Okay, thank you. In that case, if we could then move on to housing options and housing advice services update with staff consultation programme on page 1.
So I believe we've got Leslie Coburn here, and Leslie's going to take us through. Unfortunately, Maxine can't be here today as she's going through a small operation. So Leslie works alongside with Maxine and has been leading in some of the work. So I probably want to just hand it over to Leslie.
Thanks, Convener. Thanks, Kate. This is really quite a brief paper, just for the board to note progress on a staff consultation exercise that has been carried out based on the redesign of the housing options and homelessness advice service. The paper asks you to recognise the next steps in implementing governance structures and an overview of the staffing model in order for the service to deliver 100% community-based temporary accommodation model and decommission the Inverclyde Centre. The report considers imminent housing legislation which will recognise our collective responsibility for homelessness prevention by implementing statutory duties across the wider public sector, and it provides progress report on methods of communication that were implemented and the principles behind the consultation process. There is some detail on the statistical return from responses to a staff survey, an online staff survey, and we did undertake a you said we did approach to addressing some of the concerns that were raised at 4 focus groups that staff attended. A further 2 workshops were held, which revolved around the structure of the workforce and delivering an out-of-hours service, and the paper goes into some detail on that, and the options that were provided to staff in terms of how to deliver those things. The paper also highlights some of the positive feedback, both from the staff group and also from a group of people who have lived experience of homelessness. These are a group of 9 associates that are currently working with Homeless Network Scotland to provide input to the strategic process of the redesign and to move forward, providing input to the decision-making process in housing options and homelessness. There is a recognition of the need to implement a modern rights-based system that prioritises rapid rehousing and early intervention, and these priorities that we hope to achieve in Inverclyde align with the national direction of travel in homelessness policy.
Leslie, thank you very much for that. I will open up to the colleagues. Do you have any questions or comments at this point? Gemma.
Service have raised slight concerns about the out of hours.
Sorry, Gemma, I think we missed the first part of that. Could you repeat that? Is that okay?
Yes, no bother. So thank you for the support. Start with the recommendations about the out hours on call rota that the staff members are going to be looking to start. There's been concerns raised from staff regarding the contractual requirements of this, because previously it had been grade 10 and above, I believe, it operated this way. So there is concerns from staff for that. And also I would just like to ask that the details of this report be shared with staff group after today's meeting, just so they're aware of what's been brought to IJB, and if feedback for today's meeting can be shared with them. That would be great. Thank you.
Thanks, Kate. Thanks, Kate. Thanks, Gemma. Sorry, I'll ask Kate to come in at this point if that's okay. Kate.
Thanks, Gemma. I think that it would probably be best served if we have that discussion with the staff. From you raising that here, it would have been helpful if we had been aware that that had been an issue for staff prior to the IJB, because it is an operational issue that I think that we could work through out with the IJB, and happy to do so. Leslie, is that something that you would take forward from here?
Yes, absolutely. The grade 10 and above staff will still be expected to provide a level of support out of hours as they do at the moment. This is a totally different approach to delivering support to people out with office hours, and I'm happy to go back to staff and discuss what that's going to look like.
Gemma, are you content to take that forward with Leslie then offline?
Yes, that would be great. Thank you.
Thanks for that, Gemma. Colleagues, any other questions or comments at this point? Becky? You don't need to apologise.
Thank you so much, Leslie. It's really great to see the level of staff engagement that's happened since we approved this 4 months ago, and so thank you for that. Just a basic governance question. I was asking where the programme board reports to in terms of the changes. Thank you.
So the programme board reports to the senior management team. So the outputs from the programme board will be discussed at the senior management team, and then we will make a decision around where the governance sits with the IJB. The council is a significant stakeholder and partner, not stakeholder, in this. It is their property, it's a delegated function. So there will also be papers that will go to the corporate management team, and it's part of the change process for Inverclyde Council, so the governance sits there too. So it's got a dual aspect to it.
Thank you.
Thanks for that, Kate. Thanks, Becky. Any other questions or comments? Colleagues, no, in that case, are we content to take the recommendations of the paper as is and note? Excellent, okay. In that case, we'll then move on to agenda item number 10, Chief Officer's Report. Is this yourself, Kate, or is it going to be Katrina today?
No, I'm happy. I'll find myself no,
You can
so
fight
sorry.
over it.
I'm sure, sorry, Katrina. So, I got the good news to talk about delayed discharges. I know that I've been, well, Katrina has been in the frame to take things forward, but I have been keeping an eye on things as you can imagine.
So you're coming in to take the credit, is what you're saying?
No, I'm not. I'm giving the credit to the team and Alan's team, because actually last week there were several days we had no delayed discharges in Inverclyde. So the people that were waiting to delay discharge were up through the AWI process. So we had none for a couple of days. So I would want the IGB to acknowledge that. That is the first time that we've seen that in Inverclyde. We continue to perform strongly. We are probably the strongest performer in this area nationally, not just within GG&C. So the amount of work that has went in by Alan and his team and its whole system in many respects, because that would be our acute colleagues too, have been phenomenal in this area. And one of the things that are really, really important is not just about the delays. So in terms of our bed days lost, you can see that we have significantly reduced this by 200% over the last year. So the strong performance with the delayed discharges are also seeing a knock-on effect on bed days lost, and we haven't got any for mental health. So we are really, really pleased with that too. So and Alan and Katrina have been working really close together, ensuring that we're bringing the whole system. Even though we are an HSCP, sometimes that's quite hard. So I just want to get that acknowledged. Just to move on, that actually our digital strategy is in progress, and that's been presented to a senior management team. It will come to the IGB, but we're wanting to ensure that it reflects not just our strategy, but actually how do we operationalise that strategy? What does that look like, particularly now that we're wanting to invest, and that features in our earlier discussions about how we're going to get our service savings in the future, but we are investing quite significantly in digital services, so we hope that that will reflect too and allow the IGB to see what our ambition is there. And also we need to make sure that we are talking to our people and our communities around that, because it's not straightforward in Inverclyde, because we do have digital exclusion as well, and is there ways that we can do things differently to ensure that our most digitally excluded are still getting access. And there'll be probably a small test to change that we're keen to kind of take forwards, and we'll bring that back to the IGB probably in the next few months, around some of our kind of place-based approach, around in an area that we have our greatest worries around health and social inequality. So we hope to bring something here. So in terms of 4.3, I had asked that the IGB see this report or just contain it within the Chief Officer. So I had the privilege of going out and visiting our asylum hotel. And it's an area of work that we don't really profile through the HSCP, but we're quite different. We're the only place in Scotland that has got a health team. within that hotel, and if you can say it's a team, it's not a particularly big team, but actually the impact of what that team does. So if you look at the graph, and I just want to apologise because it's black and white and I can make it out myself very close lot. So a point of clarity that we probably need colour graphs in the future to kind of work that out. But this is contact avoidance, okay, for primary care services, for our GP and for our acute colleagues. So this team provides that level of intervention to stop people presenting at our primary care services. And if you think about some of the narrative, particularly when I first came into post about the impact that our asylum population was having on our health team, our health economy, etc. You know, you can see that by doing things a bit differently and developing relationships with our asylum community, it's not had much of an impact because we've done things differently. So I would just want the IGB to acknowledge the work of that team. I'm really keen that the new chief executive goes out and visits the team. And I just want to thank the team because it's quite humbling. And if the IGB ever wants to go down, any members, you know, I mean, to go and visit the Asylum Hotel and visit the team, I would encourage that because I was blown away with what they've done with very little. So they've put in IT skills training with nothing, just like actually getting relationships with the local community to donate things. They have a clothing bank. They have our health improvement team are in working alongside our health team to give the opportunity back to our people that are asylum seekers, particularly within the hotel, to prepare their own foods, which they're through the use of community resources or community centres. I understand the food's absolutely fantastic and it's delicious and much more healthier. So I understand and our Indigenous offering. So I actually want just the IGB to acknowledge some of the work that's been going on there quietly. And my last couple of things is just to acknowledge the HSCP awards. We've seen a richness in the nominations, and each of the award categories will be taken forward from the NHS award ceremony in May, and I think to the council award ceremony. I can't remember when that is, and also that our pharmacy services won our pharmacy services staff awards the other day there. I don't think it would have been yesterday, you know, I mean, but whatever day it was. So just to acknowledge Nicola and Nicole and Laura. So I don't have anything else more to say. Katrina, did I do all right?
You did fantastic.
You know, so if anyone wants to ask any questions, Katrina's here. Thank you.
Thanks for that, Kate, for coming in and stealing the credit from Katrina and the team. Cole, do you have any questions or comments at this point? I would just like to say, in terms of asylum health, if we could actually arrange a visit, I noticed looking around the room and certainly online as well as what nodding in your request that we could come down. I would very much welcome that as chair, and hopefully colleagues will join me on that as well. That would be fantastic. In terms of delayed discharges, true interest for me because I obviously sit on Glasgow as well, and Paul, as chair of Glasgow, knows the particular challenges we've got in terms of delayed discharges as well. So what I would strongly encourage, I'm sure you're doing it already, is actual sharing of experience and practice. Now, I'm conscious that things that work here will not necessarily scale up, but there's going to be some learnings that certainly Glasgow and the other 4 HSCPs can actually take away from this. So I think it would be very good if we can actually share our experience here, because what we're doing works and works extremely well. It's something I'm particularly proud of as chair. It's a good news story. I don't take it for granted because I know there's a hell of a lot of work goes into it. So this isn't just we've done it now, we've cracked it. I know this is an ongoing process. But thank you very much for that. Okay. In that case, before we move on to, I guess, the private session, if you will, with items 11 onwards, Diana, I'm afraid I'm going to embarrass you now. Yes, I'm afraid Diana sadly is retiring soon. So if you're okay, I'd like to sort of read out a few words if that's acceptable to you. Just embarrass her. I'm going to do it anyway, so you can just nod or just pretend you're not here. So Diana has been an active member of the occupational therapy profession for nearly years. After initially obtaining a BSc Honours in ecological science, she decided to wander down a different career path and pursued the quest to become an occupational therapist. Qualifying in 1984, Diana was initially based in Fife, always dedicating her practice to mental health. Working her way up the grading ladder, she became the head OT at Stratheden Hospital with management responsibility for a mixed team of nurses and OT staff. Due to family commitments, Diana moved over to the West Coast and started working for Argyll and Clyde within Inverclyde in 1993. Working as a busy mum of four, Diana worked part-time in Inverclyde, continued to focus on mental health, initially working with a day hospital, and over time, working across inpatients and community settings. Diana took an interest in union duties early in her career, and over the last years, her contribution, support, and ability to remain an impartial advocate has been invaluable. In 2022, Diana decided to take up partial retirement and return to work solely in her union capacity. Her commitment has been wide-reaching, including roles such as chairperson, vice chair, disabled members officer, welfare officer, retired members officer, young members officer, women's officer, LGBT officer, black members officer, and finally, British Association of Occupational Therapists coordinator. Good grief. Is that enough?
Read all those.
According to this, you have.
Just be AOT.
Now Diana's decided to pack up the ID badge for good with time to focus on herself and her family. She's a grandmother with a passion of playing the fiddle for the Scottish Fiddle Orchestra. So I think if anyone can just join us in the traditional way, I'd like to thank Diana and her husband Chris a very happy and healthy retirement and sincerely thank her for all her service. Diana, thank you so much. And you don't need to do a speech unless you want to say a few words. Excellent. Okay, in that case, if we can move on